EUS-Guided Trans-rectal coiling and glue injection of small bowel ectopic varices in a decompensated cirrhotic patient with ascites. 53-year-old female presented with hematochezia since 10 days. She had a history of decompensated cirrhosis with ascites secondary to NASH. Upper GI endoscopy performed elsewhere showed small esophageal varices. A CT scan performed showed small bowel varices, which was away from the rectum, and you can see the small bowel and the tuft of varices on the CT scan. She also had ascites. She was referred to our hospital for further management. On presentation, she was in hypovolemic shock on vasopressors. Hemoglobin was low, 6.1, and she had severe thrombocytopenia with platelets of 76,000. A colonoscopy with terminal ileal intubation was performed, showed fresh blood throughout the colon. We requested our IR colleagues to help obliterate the small bowel varices. They obtained a venogram from systemic approach, but were unable to access the varices. Ectopic varices were not accessed, so therefore bleeding could not be controlled. Portal vein access was not performed in view of coagulopathy and ascites. She continued having bleeding, requiring multiple units of transfusions and vasopressors in the ICU. Management options including TIPS versus EUS-guided coiling and glue injection versus surgical shunt were explored with the patient. Transrectal EUS was performed, and you can see there's a large amount of ascites across the rectum. But as the scope was maneuvered, we could see the varices, and you can see as the scope is turned around, a tuft of varices with that's inflow and outflow were identified. Paracentesis was performed and 2 liters of ascitic fluid was removed. Following removal of the ascitic fluid, you can see the proximity of the varices to the rectum. You can see the small bowel and the ectopic varices was clearly identified. Across the rectum, across the ascitic fluid, and through the varix, a 19 gauge needle was advanced and 15 millimeters of coil was deployed successfully. Following coil deployment, 3 cc of glue was injected gradually into the ectopic varix. Now you can see the glue being injected, and this was followed by normal saline to clear the needle, and subsequently the needle was removed. Post glue and coil, you can see there's a complete reduction in flow inside the varix. Post-procedure bleeding stopped, vasopressors gradually reduced, and the patient was discharged in 2 days. So in conclusion, ectopic variceal bleeding can be challenging to manage when site of bleeding is inaccessible via transmural or vascular approach. EUS provides a very novel approach with transrectal coiling and glue injection in this particular case for ectopic varices. Procedure demonstrates feasibility and safety of this technique despite presence of large amount of ascites. And EUS can be used to access distant sites which were otherwise not accessible via transmural or vascular approach.